Hello, my name is Daniel Schramm. I am one of the fourth year PM&R residents here at IU, and I will be presenting as part of Care Week a case report of a patient seen with Dr. Ann Hulme, who is a sports fellowship trained PM&R doctor who is one of our staff here at IU. The case report is titled Talar Head Stress Fracture in a Ballet Dancer. Before we get into anything, for my disclosures, I have no financial interest or relationships to disclose. So let's get into the case. A little background to start is to touch on the anatomy and prevalence of talar head injuries, fractures, and microfractures, basically, or stress fractures. This case was chosen to present due to the rarity overall of these injuries. Talar head fractures only represent 0.1 to 2.5% of all orthopedic fractures. The talus is the second largest tarsal bone. It has a head, neck, and body as outlined in this picture below. And it has no muscular tendinous attachments. It's supported by a joint capsule synovial lining and then numerous ligamentous attachments. Of all orthopedic talar injuries, the neck fracture is the most common, representing about 50%. And then the talar head fractures are much rarer, accounting for only 2.6 to 10% of all talar fractures, excuse me. Talar stress fractures are similarly rare, although there's no concrete prevalence data described in the literature. Based on case reports, would suggest that the majority do occur in the talar head. So how do these talar injuries present? Most patients, they will present after a fall with complaint of pain in the talonavicular joint region with or without swelling or bruising. Talar fractures are often missed on initial presentation as they can be difficult to see on plain radiographs. Definitive diagnosis is made with further imaging and follow-up after patients have not responded to the initial treatment and have prolonged pain. The mechanism classically was associated with this high-impact, high-velocity injury, with this term coined back in 1919 relating to injuries seen in pilots. The first case series was reported by orthopedic surgeons in the Royal Air Force due to crash landings or parachute injuries with pretty significant high velocity lower extremity injuries. There is a growing body of evidence, however, within the sports medicine population, and primarily in limited case reports, that kind of broaden the mechanisms described, including axial force on a fully plantar flexed foot, inversion, and hyperdorsiflexion. So how are these fractures managed? As far as the larger talar fractures, if they are displaced, the management is pretty straightforward based on the degree of displacement. So they would have some imaging done. Based on those findings, the most common result would be going to orthopedic surgery for an ORIF. Non-displaced fractures are a little less black and white. They're treated non-operatively, but there are no strict guidelines regarding the conservative management of these injuries, and the data is limited to case reports such as this. Various protocols have been proposed or described. In general, they include pain control, immobilization early after injury, restriction of weight bearing, compression, ice elevation, and then a gradual return to activity in the sports population. Now to get into our case, a little background. Our patient, she's a 19-year-old female ballet dancer, now 20. She presented initially to our clinic for evaluation of right ankle pain approximately a month after her initial injury. In clinic, what was described was an ankle inversion injury while she was dancing. She had heard a pop at the time with an immediate onset of pain along the lateral ankle. She was not able to ambulate for about 20 minutes afterwards. Fortunately, she was a member of prestigious university dance program, who had a dedicated athletic training staff who managed this and worked up the initial injury. She was treated for an ankle sprain and basically referred after about a month due to poor response to their conservative management. So on consultation, she was describing continued pain along her lateral ankle, which had improved somewhat initially with her conservative management, consisting of rest, elevation, icing, and over-the-counter NSAIDs. Her pain relief had plateaued, and she was unable to return fully to her ballet practice due to pain with virtually any activity. Her physical exam, she did have some mild swelling and faint healing ecchymosis surrounding her lateral malleolus with tenderness to palpation of the inferolateral malleolus and fibula. There was some reduced active and passive range of motion in ankle inversion and eversion, and on strength testing, her strength was mildly limited in ankle plantar flexion and inversion. An X-ray of the right foot and ankle, which was obtained prior to her appointment, demonstrated anterior tibiotalar fusion and os trigona, and they did not identify any bony fracture at that time. The patient was instructed on non-weight-bearing precautions following our first consultation, and she was prescribed and given a controlled ankle motion or CAM boot in clinic. We did order an MRI given failure to respond to initial conservative management and put in orders to follow her up pretty closely. So copied here is her MRI finding. She did have numerous ligamentous injuries, contusions, and what we kind of focused in on as it best corresponded to her pain was this possible non-displaced fracturing of the plantar aspect of the talar head. It is best described here in our still that I took from the MRI report. So how did her treatment regimen go? For follow-up, we were following her initially at approximately 1 month intervals. We were seeing some gradual improvement in pain with the restriction in her weight bearing in the CAM boot initially. So she would come in, she would report improvement in her pain, and then on examination, the edema had resolved, range of motion was improving as well. We did prescribe a longer acting NSAID to be taken regularly and given instructions for icing between her work with PT. She had progressed to weight bearing as tolerated in her CAM boot about 12 weeks after her initial injury and was cleared to ambulate household distances out of the boot. And then at 4 months follow-up, she was cleared for weight bearing as tolerated out of the boot and instructed on a gradual return to activity with the goal of having that closely supervised by her athletic training staff at her university. Unfortunately, she did experience a plateau in her recovery. So at about 5 months follow-up, she remained unable to fully participate in dance activities. So she was not able to resume her ballet practice without experiencing pretty significant pain in the same area that she initially presented with. This also presented with worsening of that ankle swelling that had previously resolved and tenderness to palpation on our physical exam. Just to briefly talk about kind of next steps for her, we are actively continuing to work her up. So basically, we have ordered a repeat MRI for this patient. And in addition to that, we are working up for RED-S or relative energy deficiency in sports. This was something that she had been worked up and was negative for previously. And on our screening questions at her initial consultation, there were no red flags. But whenever a patient is not responding as well as you would expect, especially healing after a stress fracture, it's prudent to look further into this. So that much of that workup is ongoing. And I think, as we'll talk about later, the issues with this case do illustrate some of the common issues with talar head fractures and stress fractures. So for our discussion, as we said previously, this case was chosen because it represents a very rare injury. The majority of these talar head fractures and stress fractures, primarily being seen in higher velocity mechanism of injury, and with only recent case studies being dedicated to these injuries in the sports population. So tried to isolate a few specific considerations within ballet and dance in general. So professional dancers, and especially dancers in this kind of university type program, they undergo strenuous training. They have regimens including rehearsals and performance schedules, which can result in repetitive trauma. And it is that repetitive trauma that is associated with stress fractures over time. There is a thought that younger dancers are actually at greater risk of injury. It's likely that their technique is not as well honed as more experienced dancers. And there's also a risk of especially the stress fractures as they progress to a more rigorous training schedule while becoming full-time dancers. And I would say, as an aside, speaking to this patient, you do learn a lot about the rigorous training schedule that they have as university dancers. The talar injury, it's most associated with an increased force through a plantar flexed foot. This was seen in multiple of these isolated case reports when they described the mechanism of injury, and would stand to reason that there are increased forces placed through the feet in ballet, especially in the pointed technique. So also not unique to our case, but rather important, is that this illustrates the challenges with diagnosis and management of talar fractures generally, talar head fractures, and stress fractures. So these are often misdiagnosed on presentation. This was certainly the case of our patient. She was diagnosed with an ankle sprain after an initial x-ray was negative for a fracture. Plain radiographs frequently do not demonstrate a fracture or injury, and they are only discovered on further imaging, in our case an MRI, ordered due to prolonged pain. Unfortunately, our case also illustrates some of the difficulties with management. For one, there is no standard or expected recovery. There are no protocols described in the literature due to the relative paucity of cases. We did follow, using our own reasoning, many of the general recommendations for these patients following a stress fracture, and basically return to play after an overuse injury. So immobilization with restriction of weight bearing, compression, ice, and elevation. The non-surgical management remains complicated, a little bit vague, and it seems to be pretty individual, with some case reports reporting pretty darn good response to the conservative management that we prescribed, and others with prolonged pain, such as we've seen in this patient. Lastly, to include my references here, some of these I just took basic anatomy from, and then I did include many of the case studies that were isolated that I reviewed, both for talar fractures and talar stress fractures. Thank you all for joining. I'm sure there will be an opportunity to answer any questions. And thank you very much.